Welcome to The Backstory with Dr. Ricky Singh. This podcast is focused on bringing you the latest research-based information about dramatically improving health, well-being, and quality of life. And here's your host, Dr. Ricky Singh.
Welcome to The Backstory. Today we're recording this episode just as Diversity Week at Weill Cornell is wrapping up. We have speakers coming from all over the world speaking on the latest scholarship and initiatives related to equity, the needs of diverse populations, anti-racism, social justice, all things kind of buzzing in the media these days. And my guest today is kind of a departure from our normal episodes where we talk about specifically health and wellness and the clinical aspects of it. But I wanted to bring our guest today to talk about how we can improve access to patients who don't otherwise get access to these health and wellness topics. So my guest today is the Inaugural Senior Associate Dean for Diversity and Inclusion and Professor in Population Health Sciences at Weill Cornell Medicine. He is an NIH-funded clinical investigator focused on unequal healthcare access and quality among underserved communities. So please join me in welcoming Dr. Saeed Ibrahim. Dr. Ibrahim, welcome to The Backstory.
Thank you, Dr. Singh, for having me.
So, before we get into the topics, and there's a lot of things I want to discuss and learn from you, I really want to kind of learn about you. Tell me about your upbringing. Tell me about how you got interested in this field of diversity, where you were before Weill Cornell. Just tell us your backstory.
Well, thanks again for asking. My background is really not that that of many immigrants in the United States. I grew up in East Africa. I was born in a small town in a country now called Somalia. My father hailed from the Ogaden region, the Somali region of Ethiopia, but I was born in Somalia, and I was born to a family of 10 kids. My father was a policeman who earned about $100 a month to raise a family of 10 kids, and I was number 3 out of those 10. I came to the United States in 1984 in a sort of an unusual way. I was actually recruited as a basketball player.
No way.
I'm
wow.
6'8" tall and still growing. But that's a long story as to how I made it from basketball to medicine. But I ended up actually attending Oberlin College, which is a small liberal arts school in Ohio, which is where I met my wife in 1984. And then I worked a little bit in basic science lab at the Worcester Institute, which is in Philadelphia. It's actually the oldest private biomedical institute, which is affiliated with Penn, before I applied for medical school. And then my wife and I both went to medical school at the same time. We attended Case Western School of Medicine in Cleveland, Ohio. And from there, I ended up at the Brigham and Women's Hospital and Harvard School of Public Health, where I did my training as an internal medicine doc and health services researcher. And then I ended up actually being recruited back to Cleveland for 5 years, and then spent about 10 years in Pittsburgh, where I was a member of the VA and the UPMC health system. In 2012, I was recruited to Penn to be a professor there and to be the chief of medicine at the Philadelphia VA for several years before I became the director of one of the centers for health services research. Fast forward 3 years ago, I was recruited to come to Cornell by Augustine Joy and Renu Kaushal, chair of the Department of Population Health Sciences, who was my intern when I was a resident. And Augustine was actually the chief of pulmonary in Pittsburgh when I was faculty there as well. So that's my background.
Yeah, it's unbelievable how many places you've seen. Your pedigree is obviously, quite impressive of all the locations you've worked and lived. One thing that we do really good in Western allopathic medicine is, I believe, we're great at treating problems. We learn disease processes, we learn interventions, medications, innovative strategies. One thing I believe we're not great at is getting into the communities and prevent things. And it's probably the way our healthcare system is developed. We're rewarded by doing. We're not really rewarded by not doing. So how did you transition from internal medicine, where you're sitting there treating chronic diseases, to saying to yourself, you know what, I need to be out there in the communities and prevent things? How did you make that transition?
So it's a beautiful question, and it's a question that I go back to actually many times. So about 25 years ago, when I was a young guy practicing medicine, internal medicine, I really wanted to sort of do something other than just taking care of patients, which is very important. I was interested in health policy. I was interested in, health services research. How do we take care of people? And I knew that I also wanted to actually understand how patients who come from socioeconomically disenfranchised communities access healthcare and how do they fare. So that actually was what got me to go back to school while I was still a full faculty. I attended the Harvard School of Public Health to learn how to do research at a population level. And I was looking for a project to sort of to look into. And one of the first things that came to mind was a young rheumatologist at the University Hospitals of Cleveland came to me and said, well, there's a marked disparity in the use of knee and hip replacement, which, as you know, are the most commonly used surgical treatments for patients with end-stage osteoarthritis of the knee and hip who have exhausted all other sort of treatments. And I said, well, why is there a disparity? And he said, no one cares because it's an elective treatment and no one has studied it. That was actually sort of the signal for me to sort of say, well, this is really a good subject to understand several things. One, how do we care for patients who have chronic diseases that are highly prevalent, like osteoarthritis, which is one of the leading causes of disability, as you know? Secondly, how do patients from different ethnic groups and backgrounds make decisions? If this is elective, that means there's discretionary decision-making. So how do patients arrive at these decisions if a doctor doesn't look them in the eye and say, you need this? So I thought this had a sort of a social studies background to it. And then, of course, if you want to study the utilization of healthcare, one of the best ways to do that is to go back to large data sets rather than do prospective studies, because that's how you really understand the variations. So that's actually how I got into that. And then once I realized that disparities weren't unique to knee and hip replacement use because they are everywhere, it became very clear that the studies that I was doing to understand variations in the use of knee and hip replacement were actually applicable to a whole host of other community health matters.
You hit on a point that we don't get much training on in medical school. We get biochemistry, pathology, physiology. We don't really talk about the social determinants of health and how that impacts population health. And, I'm here now 12 years in practice. This is all new stuff to me. And I'm admitting it, that this is a foreign field to me that has really piqued my interest lately, which is why I wanted to bring you onto the show and talk to you about it. I want to talk a little bit about definitions.
Yeah.
And one of the big things that came up recently was health equity and health equality. And I thought these words were interchangeable. I've used them interchangeably, but I've learned that they're not. And equity and equality are different. So tell me about these two words in particular.
No, that's a really great question, Dr. Singh. So it used to be that we used these words interchangeably. Health disparities, health differences, healthcare variations, equality, equity. I think we're now settling into equity versus equality, and this is sort of the most nuanced sort of definition, I think, as we think about access to healthcare. Let me use a simple example of the difference between equality and equity. That obviously, I'm using a very simplistic example, but it could really, you could use a much more complicated social issue to understand this. Let's say that two patients come to you with the same diagnosis of hypertension. Equality would be if you offered them the same medication, one medication, same dose. Chances are one patient may actually sort of benefit from that, and their blood pressure, his or her blood pressure, may be controlled by that. But another patient may not, because the etiology of their problem varies in ways that are not always clear to us. So equality will be just giving them the same medication and the same dose and expecting the same results. Equity would be to sort of say, what does it take to control the blood pressure for each of them? If it takes two medications as opposed to one for one of them, then that is an equitable way of treating hypertension, because the equity implies the intended outcome. Equality is just simply an equality of opportunity. It doesn't always translate into outcomes of that you are seeking.
Right. And we sit here, at Weill Cornell, and I think in the rehabilitation department, we have something called resident clinic. And, we kind of pat ourselves on the back. We're saying we have resident clinic. It's open for any patient, no insurance, underinsured. And we're thinking to ourselves, we are offering an equal opportunity to come seek us.
Exactly.
Yet what we missed the point on is, what about those patients who can't actually come see us?
Exactly.
They don't have a ride. They don't have a car. They don't have transportation. They have language barriers. And we kind of cast them aside because we're saying, if you come to us, I'll treat you the same. But how do we get in there? How do we actually go to those communities and help them?
And that is really the essence of the issue, is that you have to understand what are the needs of those patients who are not similar to the other patients that you are treating. And I think if you understand their needs, you may be able to actually offer them a better or a more tailored sort of intervention or care. And that is really the difference between equality and equity.
No, I loved your analogy. I think that makes complete sense. One is kind of prescriber-based or us offering treatment, and one is a systems-based approach.
Exactly. And, it's very interesting. This is a conversation that I have with orthopedic surgeons all the time because of the subject that I study. And when I present my work to orthopedic surgeons, they often sort of say, but we treat patients the same way. I really don't believe in any of this stuff. I take care of my patients the same way. And actually, in most cases, that is true. But the problem is not everybody needs the same thing. And that is where sort of equity comes in. You have to meet the patient to where they are. It's not just enough to simply say that I provide the same care to everyone. Yeah.
So that brings me to another point about another determinant of health, which, we talked about access, we talked about getting into the communities and trying to bring them to us, or we should go to them. There's another concept of bias. There's an implicit bias, there's an explicit bias. Some of us think none of us have bias. I would like to say I don't have any biases. I would love to say that to you, but maybe there is something ingrained in me from my parents and grandparents that I have some. Tell me a little bit about how implicit bias works in healthcare and how, if at all, that could affect healthcare outcomes.
Absolutely. Another great question. Bias is something that happens on two levels. On one level, it's blatant and obvious. For instance, you'll sort of say, I'm a man, I don't take care of women. And your approach will be sort of impacted by that reality. That's a blatant, obvious bias. The more subtle and the more sort of less observed bias is the bias is that the person who's committing doesn't even recognize, because they're so subtle and they're so part of the person's sort of thinking. So just to give you an example, if two patients come to you, with knee pain problem, and one patient, and you happen to be a golf player, and one patient says to you, "Doc, I can't play golf. This knee is killing me. I need it to be fixed." The other patient comes to you and says, "Doc, I have knee pain." Well, guess which one of those patients will get more of your attention? The one that really sort of resonates with your own perceptions and feelings and background and social sort of... and this example is actually one of the reasons why there's marked racial differences in the use of knee and hip replacement, because orthopedic surgeons can actually relate to someone who sort of says, "I can't play golf," because this used to be called the golf player's procedure, as opposed to sort of a typical man who's in inner city, sort of who's never played golf, who doesn't explain what their lifestyle is to the doctor. The doctor can't relate to his or her lifestyle. They will be less likely to offer the treatment, not because they don't like them. It's just because it doesn't resonate with them.
Yeah, I mean, your example hit the nail on the head, and I'm like feeling a little guilty because I have golf patients. I am a golfer myself.
Right.
And when a golfer comes to me with an injury, I can sympathize, and like my desire is to get them back on the golf course because I know mentally how important that is to them. Whereas another patient who says, I want to pick my grandkids. Yeah. I can't really relate to that. Not that I'm not going to offer beautiful treatment, but you're right. I mean, all right, listeners, you've heard it. I have implicit bias towards golfers. I'm going to work on it.
But the beauty of it is, I gave you a very simplistic example, but the reality is that there are a lot of other biases that we have based on where we grew up, who we grew up with, the social settings. And so it's not that it's sort of difficult for us to have difficult time relating to patients who sort of come to us and sort of say, doc, I have pain. And you sort of sometimes say, well, why aren't you doing this and this and this? Because that's what we do in our culture. Well, the reality is that that's not necessarily what he or she does about pain. So that's the kind of biases I think that are often so prevalent in healthcare. Yeah.
How do we go about studying that? I mean, it seems challenging to study implicit bias and how it would affect outcomes. No, your example nails it for sure. But how do you go in there to the faculty and attendings and figure out what their implicit biases actually are?
Well, first of all, everybody has biases. This is not unique to one group or one individual. So the question is, what biases do we have? It's not, do we have some or not? So it's one thing to sort of recognize your own biases. And there are some studies, like the implicit bias assessment trainings that we offer now, that allow people to sort of take this and sort of understand if there are some biases that they need to keep an eye on as they interact with people. So that's one way to do it. The other way that some people have recommended is that we need to teach people, particularly young physicians and healthcare providers, about cultural competency. The challenge about cultural competence is there's so many cultures, and you can't teach people to be sort of facile with all cultures. But I think openness to learning about other people's culture is something you can teach. And if you could do that, then you will be actually halfway there for helping people deal with their biases. I don't think that the idea is to eliminate bias. The idea is to recognize it and to moderate it and to make sure that it doesn't entirely invalidate your treatment decisions.
Let's say we are successful at creating openness in our faculty, in our healthcare workforce. There's still this group of patients who are probably going to respond to a healthcare provider that looks like them more than like me. Like, you look at me, I have a turban, I have a beard, I look different than a majority of the patients that walk around in the hospital, majority of the faculty. And some patients may not want to come to a doctor that looks like me, which is completely their right. So in order for me to get to that patient, I need to employ staff that look like my patients. So creating a diverse workforce, is that one of the steps that we can move the needle?
Absolutely. Yes. So how do we deal with bias in healthcare and also healthcare disparities? There are many, many different things we could do. One is we can educate our young future healthcare providers. Another is that we could study the impact of these biases and disparities on people's lives. We could also even empower patients. But one of the increasingly important things that we've noticed is that diverse healthcare workforce, whether it's scientific workforce or clinical workforce, really is more suitable for providing care to diverse communities. So if you live in New York, which is one of the most diverse cities in the country, it's very difficult not to have a diverse workforce that really reflects the community that you provide care to. And what that does is that it increases the trust level of the community of the healthcare system. So when they go to a healthcare system and they see that the healthcare system reflects the community, it puts them at ease. They are less concerned about bias, and they will be willing to accept care from anybody because the system is highly congruent with what they see in their communities. So that's one of the things that we are trying to do. So the question is, how do you get there? Well, one of the things that we're trying to achieve here at Weill Cornell Medicine, and I'm sure that other medical schools are doing this as well, and health systems, is that we really have to train the future generation of healthcare providers and seek diversity from the get-go. So we're trying to increase the representation of underrepresented minorities in medical schools, in graduate schools. And we are actually now doing a lot of creative ways of trying to recruit more diverse faculty, both for research as well as for clinical care.
So is it easy enough for us to say here at Weill Cornell Medicine, come apply to us as a medical student, and we're going to try to make our class diverse as possible? Or do we need to be more proactive? Do we need to go to those predominantly black undergraduate colleges and say, come apply to us? We are seeking you to get education here?
Great question. So there are a lot of different ways different people do it. So there has to be an outreach program that sort of brings more diverse sort of prospective students into your institution so that they know about you and they apply to you, because they have to apply to get in. So one of the actually most iconic programs at Weill Cornell Medicine is called the Summer Travelers Program. It brings 25 undergraduate students every year on campus in the summer, and it shows them what's going on. And that program started in 1969 in response to the race riots, for instance, in the United States in 1969. And it has been great. Almost 85% of the kids who have attended that program have gone on to enroll in medical school. 95% of them have graduated. Some of them are now directors of NIH institutes, like the NHLPI director is an example. So that's an outreach program. It's a sort of you go into the community, you bring the kids, you expose them, you encourage them, you help them. They become part of your applicant pool. So that's one strategy. Another strategy is by sort of removing the financial barriers, because it's very hard to get an application from a kid who lives in rural Alabama and sort of say, come to the Upper East Side of Manhattan. I mean, that's frightening enough as it is, but financially it's even more frightening. That's, I think, one of the reasons why Cornell adopted the tuition sort of free approach. So 50% of our incoming class will actually have to pay nothing to attend. And that, no debt, a medical school, for students who come from socioeconomically disenfranchised communities is another way to increase the pool of applicants.
Has it been shown that by doing so, by bringing in a diverse workforce, by training the next generation of medical specialists in a diverse way, does that net impact the healthcare outcomes in the country? Has that been shown?
So the jury is out on that. That's a beautiful question, and I think it's a subject for research. So it's theoretically it makes sense, but theory doesn't always necessarily lead to reality. So sometimes there is some disconnect. I think there's no question that there are studies that show that patients who go to a more diverse healthcare settings express more trust in the healthcare system. That's true. But do they get better care? We don't know that. But the other really sort of a related question to that is that what's the alternative? I mean, the alternative is that we know that patients who do not trust the healthcare system are unlikely to follow sort of the treatment guidelines or health advice from people. That's one of the reasons why the pandemic was more devastating to the inner city community, because one of the things that didn't happen is that they didn't take the message seriously at the beginning, because the message was coming from the government, and the voices were not diverse, they were not trustworthy to them, and as a result, they basically don't filter down into the average person. So that's the other sort of the reverse way of the harm that comes from not having diversity in the messengers.
Right. You talked about the pandemic, and we're hopefully nearing the end of COVID-19. A lot of people around us are getting vaccinated. But the other pandemic that has plagued our society, which is of healthcare disparities, whether it's chronic diseases like diabetes or cancer or heart diseases, that has affected a disproportionate group of people, similar to how the COVID-19 pandemic has affected them. And a lot of that you mentioned is related to trust in our system. So certainly here at Weill Cornell, we're making ourselves more trustworthy to the public. You mentioned the different strategies with diversity in the workforce, educating the next generation. But what about that kid that you mentioned from rural Alabama who would not have heard of us unless we went out and picked him, brought him to Manhattan, showed him the lights of Manhattan and hopefully Broadway and all this stuff? What are the chances this kid goes back to rural Alabama and impacts healthcare versus just getting this high-paying, fancy job as a specialist somewhere else?
That's a great question, Dr. Singh. And in fact, this is one of the subjects of research for some of us. So it turns out that medical students who attend medical school and graduate and become physicians who are traditionally from underrepresented minorities, they are more likely to actually go back to the communities where they came from to practice medicine. And that's very important. But that also means that they are going away from academic medicine. So they're not at Cornell's or the Harvards or the Penns where you are going to influence the future generation's perception about healthcare. So one of the sort of challenges that right now we have is how do we attract more sort of students into academic medicine, not just into medicine, but academic medicine, with the goal of sort of trying to really sort of impress the young kid in rural Alabama, and do they want to become, NIH-funded investigators, for instance. And it's not an easy thing to do because the community is still in need of doctors. So we haven't really met the community's needs. A lot of these young kids are really motivated initially by the desire to serve their community. So there are some financial incentives, for instance, that the NIH now offers, something called the Loan Repayment Program. I don't know if you know about them. But the idea is actually very much related to your question, which is the idea is how do we incentivize some kids to become investigators and researchers and become academics without sort of presenting them to a sort of economically difficult situation. So the loan repayment program was actually designed to address that, to make it easier for someone to say, if I don't have to deal with my medical school loans, I can actually become an academic because I have time to spare. And I don't have to sort of burden my family by not being sort of a breadwinner.
What have the results of this loan repayment program actually shown? Excellent
question. It hasn't been really formally studied, but it's been going on for over 20 years. So it's actually ripe for some analysis as to how did this help? I can understand why it's still difficult to do that because there are so many other variables that impact whether someone becomes an academic or not. And so it would be very methodologically difficult to sort of sort out what are the confounders of that relationship. But at some point, I think somebody needs to do this. The NIH needs to know this in order to justify the existence of that program.
Talking to you and thinking about what I've been doing the last 12 years, not sitting here and waiting for patients, but kind of sitting here and waiting for patients. I love when patients come see me. I want to impart my knowledge, and my goal is to get them back to their functional health, whether it's playing golf or playing with their grandkids and kids. I mean, that's what I enjoy doing on a day in and day out basis. But with speaking with you and, this last week with diversity and inclusion, it makes me think maybe we could do more. Maybe we should create strategic partnerships with community physicians or put some of our physicians in the communities every once in a while to build trust with our citizens, our community, impact healthcare in a positive way. I mean, finances come to mind, right? Why isn't this working? It's a system thing. It's a healthcare system in the United States probably preventing this. You are the director of health in the United States. You have an unlimited budget. How would you change things on how healthcare is delivered in the United States?
That's really, really a great question. One of the things that contributes to disparities that many of us, even physicians, don't realize is that most community members or patients don't have similar access to the best care. So just let me give you an example, and I don't want to pick on institutions. So, if you are a Medicaid-insured patient who's still an immigrant and you live in Manhattan and you need knee replacement, what are the odds that you're going to get it at HSS, for instance? Zero, right? So that's a profound difference in terms of just getting access to the needed care. So, and part of it is the way that we finance Medicaid, for instance, and Medicare and private insurance is so different. So one of the easy ways, for instance, to improve access at a policy level, at the economics level, of communities in need of better access to high-quality care is by making Medicaid reimbursements similar to Medicare reimbursements. It's a low-hanging fruit. All it takes is a political will. And that alone would actually expand access to care, because patients could still get access to regular care, but not the top-of-the-line care, because for them to get the high-quality care, they need a better insurance. So that's one way. So addressing the insurance disparities in healthcare in the United States, I think, is one of the most important ways that we could do something about it.
That's a whole conversation for another time about insurance. I think I'm with you on the socialist level. I
Yeah.
think, we could do a better job of providing care and access to a bunch of patients. I don't think private insurance needs to go anywhere. It's got its place. It's got its role. But certainly for the government-funded insurance, we could improve their quality of health. And that would probably lead to better outcomes and overall less utilization of the system anyway.
Exactly.
And that's a number that you don't talk a lot about, or we don't talk a lot, because it's not really tangible. We know what we spend. It's tough to really quantify what we could save by impacting their health. So, great point. I want to touch about one more point you mentioned earlier about your study regarding osteoarthritis. Musculoskeletal care, sports and spine, that's my backyard. And, that's where we see a lot of patients with joint arthritides. What were the results of your study, and what were some of the goals in changing how those patients who had some hesitancy for access of care, how did you change their minds?
That's beautiful. So the way I started my work was, first of all, I wanted to know, is this really disparity real or not? And so I did a large database studies comparing African Americans, which are the most extreme on one end of the utilization kind of spectrum, and on white sort of patients. And it's been very consistent, both using Medicare data sets as well as private data sets, and even VA data sets, where access to care, by the way, is less of a problem, because that's a major confounder outside of the government hospitals. So we studied this, and we confirmed that there is a really long-standing disparity. Africa, just to briefly tell you, African American patients, particularly men, are about 40% less likely to undergo knee and hip replacement if they need it. So then the question became why? Why? What's this? Is it insurance? Is it sort of the orthopedic physician bias? Is it patients just don't want it? So we had to sort of design studies. So we've done studies funded by the NIH to study all of those. We looked at whether insurance bias is an issue. It turns out that it's not about insurance. 60% of all knee replacements are paid for by Medicare. So more importantly, in the VA, the disparities are the same. So we figured it out very quickly that it's not about insurance. Then is it physician bias? We actually did studies, audio taping, orthopedic surgeons talking to patients black and white, and looked at decision making. And what we found is that orthopedic surgeons often treat patients the same way. They don't. Our hypothesis is that orthopedic surgeons are racists because 96% of them are white men. So, but that assumption really sort of didn't hold, because they are very actually reflexive in how they do business. It's how they were trained, and they treat the same patients the same way. And we even audio taped their conversation with the patients. It's very similar, regardless of. But one of the things we found is that the way different patients from different social communities express their problem varies, and it influences the decision making. Like, for instance, an African American patient may come to the doctor and sort of say, "Doc, my knee hurts," and just sort of leave it at that. Another patient may come and sort of say, "Doc, this is really impacting my quality of life. I can't walk, I can't run, I can't play golf, I can't take my kid to the playground." That sends a different message to the orthopedic surgeon. So depending on how the patients frame their issue, the orthopedic recommendation for treatment varies.
Yeah, and what you just said reminds me of a patient story. I saw him recently. Elderly man, 67, 72 years old, African-American gentleman, came in with knee pain. Walked in and said, "Doc, my knee kind of hurts." So we go over the history, and he had a knee replacement 8 years ago. Uneventful. I was like, "You know what? Let me see you walk." And he was walking a little bow-legged. One leg looked a little different than the other. I was like, "Let's get an x-ray. I don't know really what's going on. Let's get an x-ray." His prosthesis of his knee replacement was completely out of the bone. Out of the bone. He didn't know about it. He's like, "Yeah, I have a little bump on my thigh." I'm looking around. I'm like, how does he not know that this is happening?
Exactly.
So I send him straight over to orthopedics, one of our colleagues actually at HSS, and he had the revision done, doing excellent. But you're right. He probably had never really complained about his knee.
Exactly. So the way you frame what you complain about, this is really interesting, because we actually did studies looking at the pain tolerance level by race and ethnicity. And there is a marked variation. African American patients are much more likely to actually sort of downplay their pain. But that really affects the orthopedic surgeon's recommendations, because if you don't really complain, or if you don't express sufficient amount of pain, it does sort of affect. And there is absolutely no correlation between X-ray severity and the patient's symptom. I don't know if you know that. But there's just that correlation is terrible. So you can't rely on X-rays to tell you how much pain a patient is having. And pain is one of the major indicators for surgery when all else fails. Again, surgery is the last resort. I personally don't recommend patients to consider surgery right away. I recommend them to consider all kinds of things before they get to surgery. But ultimately, that's what happens since the condition is not curable. But to follow up your earlier beautiful question about what do we do for patients, here is one of the things we did. We actually got funded by the NIH to study an intervention study where we recruited patients, mostly minority patients, who were coming to Penn for knee pain management. And there's this well-developed knee OA decision aid that's a beautiful kind of 40-minute video that tells you everything you need to know about knee replacement and how to manage osteoarthritis. It's designed actually not to promote surgery, but to promote alternative care, but it tells you the signs and the complication rates and the benefits and the risks of the treatment, and it's done for lay people. So we randomized patients to view this before they saw the orthopedic surgeon versus to just go straight to the orthopedic surgeon. And our hypothesis was that patients who are more informed about the benefits and the risks of the treatment would have a better conversation with the orthopedic surgeon and may actually end up with different results. That intervention increased, among those who saw the video, the rate of their undergoing knee replacement went up by 85%. Among minorities, we're not even talking about comparing them to whites, just among minority patients. And the reason is because orthopedic surgeons don't have time to tell you everything you need to know about knee management, OA management. But we did that work for them by educating the patients. So simple education of the patient empowers them to have a better conversation with their doctor, and that's one of the interventions we recommended.
No, that's great. I think that makes me think about what we could do better at our Weill Cornell Spine Center in terms of empowering our patients to make educated decisions. And that seems simple enough. And
it's simple enough. And guess what? The knee decision aids are now actually becoming uniformly available. In fact, Medicare may require it.
Wow.
That you have to actually show patients this before they come to see an orthopedic surgeon.
Well, I think the results of that study are truly compelling. The intervention, albeit sounds seamless, has tremendous impact on the healthcare of our patients. Dr. Ibrahim, I could talk to you forever about this kind of stuff. You're really giving me a lot of research ideas about where I want to maybe take my career, separate from clinical spine and clinical rehabilitation medicine. So I really, really appreciate that. So at Weill Cornell, we are doing a great job of trying to create a diverse workforce. We're educating the next generation of students, residents. We're bringing on new faculty. We have a diversity council that you're a part of. You're a champion in that council. We have champions from all over different specialties, including rehabilitation. Any final thoughts? Anything we didn't touch that you want to say to the group?
Well, I really think I wanted to sort of say that this institution is really committed to diversity and inclusion. They are really doing as much as they can relative to other institutions. And I think the idea of sort of making diversity and inclusion and equity in general as part of our culture, I think we are making progress. I mean, I don't know if you know that Cornell actually won the HEAT Award, which is the Health Equity Excellence sort of award, 3 years in a row. And I think they are basically recognizing what we're trying to do. And so we have a long way to go, to be honest with you, to achieve a sort of complete equity in all things. But this is a long journey, and life is a long journey, and the first step is as important as the second one.
Well, Dr. Ibrahim, I really appreciate you taking your time from your schedule and talking to us, and certainly enlightening me about the field of diversity, inclusion, health equity. I think we have moved the needle here at Weill Cornell. We certainly have work to do. If we finish it on our lifetime, great. Otherwise, we'll leave the next generation one step closer. So thank you for being here. Thank you for your listeners listening in and tuning into the podcast. And on behalf of my guest, Dr. Saeed Ibrahim, remember, when it comes to your health, when it comes to your wellness, we've got your back.
Thanks for listening to The Backstory. Please subscribe, rate the podcast, and review The Backstory on Apple Podcast, Spotify, and Google Play Music. And feel free to share this podcast on social media or even your own website or blog. This podcast is for general information purposes only. It does not constitute the practice of medicine, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information is at the user's own risk. The content of this podcast is not intended to be a substitute for medical advice. To learn more about Dr. Singh and his clinical research, please follow him on social media. You can also sign up for his newsletter by going to www.rickysinghmd.com. That's RICKYSINGHMD.com.